I'll call Dr. Saikumar SJ. Sir is the medical superintendent at Girdhara Institute and is a mentor to all of us there. And he'll talk on Rhexis extension and Argentinian flag sign, how to optimize outcome.
Thank you, Dr. Sandhya, for having me in this course. Dr. Namrata, who is supposed to give the keynote lecture, will join us soon, and so I will, without wasting time, I'll go into my presentation. Rhexis extension is one of the difficult things that, especially in your beginning stage of your career, you are very concerned about. But once you are reasonably okay in phacoemulsification, routine cases, the chance of Rhexis extension is very less. So you're basically looking at intumescent white cataracts with a lot of intraback pressure. And with that sort of situation, any one of us at any point in our career can have a Rhexis extension. So I'll be just showing 4 videos and we'll have some discussion on that. So this is a young patient with a very intumescent cataract, hardly any cataract, in fact, no nuclear material. And so I tried to create a Rhexis and the entire Rhexis just splits open. So this is your typical Argentina flag sign. So what do you do in this situation is that there's a very, very soft cataract, and because these forces have spread symmetrically to both sides, this particular Rhexis chance of going behind and becoming a wraparound tear is very less. So you just have a straight linear opening in the anterior capsule. All your material, cortical material and epinuclear material is removed. So you can even use a single piece lens here, but here I am using a 3-piece lens. Now the haptic, sometimes it gets a bit difficult to rotate it because you only have a split opening. So once you rotate it, you can create what is called 2 hemi-Rhexis. So cut in one direction and peel off and make 1 hemi-Rhexis there using your micro-Rhexis forceps. And similarly for the other side also you make a hemi-Rhexis. So this lens is very well centered in the back without any problems. Now coming to, so just a few points about the Argentina flag sign, the very intumescent ones, usually in young patients, intumescent cataract. The moment you nick, if you get fluid out of the IOL, you are safe because these capsules don't extend. But even if you nick, there is no fluid, there's a lot of intumescent cortex there, these are the problems. Faster in more in vitrectomized eyes and cataracts which have progressed very fast. This is the second video, where something similar to what happened in the previous one. This was not a very intumescent cataract, but there was lot, you will note that there is hardly any fluid coming out. That means the cortex there is very turbid. So it goes to one direction, I make the main wound, I try to hold it with the forceps, and by the time I exchange my instrument and try to get another instrument, this is split open. So this is a single side split. So this is not similar to the Argentina flag sign. In an Argentina flag sign, you have a split which is symmetrical going to both sides. Here it is single side, so the stress on the zonules there is likely to be more. But since this cataract was not very hard, I still decided to go ahead with the phacoemulsification. And then once the phaco was done, I extended my Rhexis, cleared up the cortex, and went in and did a IOL implantation. Again, a 3-piece lens. So this is another case, somewhat similar, but this was a very small pupil. So again, very intumescent cataract. One of the mistakes that I have made here is that my staining is not very good. Okay, so I did the staining before I put my iris hooks, and so in the periphery the staining is not too great. I am using a micro-Rhexis forceps to do my Rhexis, but as I reach here and try with my Uttarata, this has gone to the periphery. So since I've already committed on my phaco wound, I put a small nick on the capsule with Vanna scissors and then complete the Rhexis and go ahead with my phacoemulsification. So please remember that in this case, the Rhexis margin cut or the cut towards the periphery is under your main wound, and whenever you split or chop the nuclei, the whole stress is going to be there. So here I finished almost the last piece I took on with a scaffold, which I am not showing here. That is not the, so here you can see this vertical split in the posterior capsule. This is called a wraparound tear. So if you have just one Rhexis extension in one direction, especially if it is along your main wound, each of your chopping maneuvers is going to stretch the pupil like this, and that can cause a Rhexis extension. So here, again, a three-piece lens was implanted in the sulcus, and once a lens was implanted, the remaining nucleus was taken out by a scaffold technique. This is my last video. So, prevention of these double Rhexis, better staining, probably convert to SICS. This is my fourth video. So, as I mentioned before, when you have an extension which is in the same direction as your main wound, if you're sitting temporal in the temporal, whichever direction, the risk for a PC rent or a wraparound tear is more. And again, this is another intumescent cataract. Always better to use micro-Rhexis instruments in this case because it gives more control. You can hold the capsule well. Of course, you can use very high cohesive OVDs like Helon GV or Helon 5 to compress the capsule. But here I was finding it a bit difficult. I was not able to hold it. Sometimes the capsule small nick sort of goes inward, it's turned inward, and sometimes it's difficult to hold it with your micro-Rhexis forceps. And here I was trying to take it out, and as I reached, tried to give some centripetal force, again it is split open. So this is again something that you have to be very, very careful about. So since it was under my main wound, and I had not made my main phaco wound as yet, so I decided to convert into an SICS, and here I'm delivering the nucleus and inserting the intraocular lens in this case. So these are the just short 4 videos that I thought I will share. So in summary, a good staining is very important, heavy OVD so that you can press on the surface of the capsule well. Always have micro-Rhexis instruments, and it's always safer to do a small Rhexis first, decompress maybe with a bimanual, go in and remove all the superficial cortical matter, and then make a second Rhexis. That will make it things much easier. And when it occurs, if you feel it is safe to continue with phaco, especially if it is 90 degrees away from your main wound, you can, if you're confident. Do the chop without stressing the capsule too much and use dispersive OVDs. Always think of a VR backup. If you're not confident, if you think this is going to extend, always safer to go into an SICS. Thank you very much.
Thank you, sir, for those wonderful